Dr. Manoj, we are ready for the last session.
Yeah, Colonel Sitaram, this is the last case from Apollo. And I just wanted to tell you the previous patient who had pericardial effusion, she's stable, there's no more collection, she shifted to ICU. So for the last case, there's a sixth case from Apollo. And with me is Manoj, Dr. Rufus, and Dr. Aziz, he was our FNB student, and then he's now working as a consultant in Bahrain, Apollo Hospital, Bahrain. Dr. Rufus will introduce the case.
Slides.
And Dr. Alain Cribier, by the way, he's here. He is here, so he will be giving his expert comment from here.
So our patient is a 76-year-old male who had a coronary artery disease. He underwent status post CABG with 3 grafts, is SVG2 OM PDA and D1 in 2008. Now he presented to us with breathlessness, which was NOHA class 2, and exertional angina for the last 3 months. On evaluation, we found to have a severe AS with the EF of around 55%. So for the evaluation of TAVR, we did his coronary angiogram, which showed an 80 TVD with occluded D1 graft, and his STS score was 7. This is his ECG, which shows a AF with controlled ventricular rate. There is no bundle branch block. The echo shows a mean gradient of 64 and max gradient of 112. His hemoglobin is 11.6 and creatinine is 1.2. So the CT evaluation showed the aortic annulus area of 420 millimeter square. Area derived annulus is 23.1. The LVOT is slightly bigger than the annulus. The coronary heights were very good. It is 18.9 millimeter on the right side and 18.1 millimeter on the left side. The sinus of ulcer is more than 25 millimeters.
So this
you can see the annulus and the LVOT, which is free of calcium. The SOVs are adequate and which is also free of calcium. The coronary height is shown, which is also very good. Next. This is the aortic valve. You can see some calcification, otherwise it's free of calcifications. So the femorals were adequate. It is average of 7.2 millimeter on the right side. That's why we are going on from the right femoral axis. So this is a moderate risk patient with a tricuspid aortic valve with a moderate calcification in the aortic arch, and there is mild calcium in the annulus and LVOT. Our plan is to do a balloon expandable valve, which is we are planning to choose a 24.5 millimeter with planning to reduce 1 cc low. We are planning to do a pre-dilatation with 18 millimeter balloon, and we are planning to close the site with 1 ProGlide. So now we will show you what we have done till now. We have done the femoral axis, right and left femoral axis. We have parked the pigtail. Then we have crossed the aortic valve. We have placed the stiff wire in the LV. Now we are ready for the pre-dilatation.
Yeah, we have closed with 1 per close, and plan is to close with the angiosyl in the end. We have closed, in the meantime, we closed the valve with a AL1 and straight tipped wire and exchange with pigtail, and this is a extra strip guide wire. This is the guide Safari
extra small.
Extra small. And okay, we are planning to go and dilate with 18 millimeter balloon. Actually, this case is ideal for a good case for TAVR because femoral artery size is very good and moderate calcification in the aorta. Coronary artery height is more than 15, both left and right. LVOT, there is no calcification. So it's a good case, but we wanted to do the pre-dilatation because this there was some stiffness we could see, and we prefer to do the pre-dilatation with 18 millimeter. And this is the balloon, 18 millimeter balloon. That's I think that's across the valve, dilate it now.
180.
Pacemaker, yeah.
180.
180. Go ahead.
Wait a minute. Okay.
Okay.
It will.
Okay.
Good.
Oh, good. Chalo.
Facing down. One.
Good afternoon, Dr. Rath. Good afternoon, Dr. Manoj.
Good afternoon.
Yeah, good afternoon.
Sir, this is Anup. Sir, we understand we got the case details, and as you said, it's an excellent case for TAVR. Could you please clarify you are going with 24.5 nominal or -1?
-1.
-1.
-1, okay.
We could.
Anup, in our cath lab, Dr. Cribier is there. I'll just ask his expert opinion. He is there. Can you give your opinion?
Yes, well, actually, I don't know what was the size of the
23 annulus.
23 annulus, and you are planning a 24 valve, actually.
Yeah.
So 24.5 minus something.
-1.
A -1. Well, that's a good choice. Well,
24.5 is 12% oversize.
Yes,
so if
yes.
you take 1 CC it will be around 8% oversize.
yeah, which is one of the interests of the MyValve, you know, to offer so many different sizes.
And
adapted to
intermediate
each
sizes
patient.
this is a unique valve with intermediate sizes.
Yeah. And, you know, this femoral artery size is good. And aortic annulus is good, moderate calcium.
Oh, yeah. Good.
Any of the two, self-expandable or balloon expandable, any of, both of them can be done easily.
Yeah.
And height of the coronary also is good, more than 13.
Okay, fine. So that's fine.
We prefer to use.
It's an optimal case for TAVR.
Dr. Rath, sir, Avinash here.
Yeah.
Sir, pre-dilatation is essential because the valve is not that calcified.
No, it is not very much essential. This case you can do it without pre-dilatation, but you know this. It's all the individual choice because many times dilatation makes life easier, smooth. Last case, if you see the last case we did it, we thought it will be. It's a very ideal case. No need for pre-dilatation, and then we had this hypotension after putting the wire. Then we thought balloon dilatation will be required. After balloon dilatation, BP went up. All these things are there, but I'll prefer to do pre-dilatation and do the case. And there's not much of calcium, so I don't think there'll be any embolization and all these things are there, but I'll prefer to do it. You can do it without that also, but in case it doesn't go, you have to again take it out.
Well, this is a MyValve. It's not an octacore. Yeah.
Advantage of MyValve is you can, if it doesn't go, you can just pull out and.
Look at the wire tip. 1 minute, sir. 1 minute.
Okay. Okay.
Yeah.
Okay. It's okay. So you want to see the inject and see?
Yeah.
Just can you inject? Let's see.
So Anup, what do you think?
Well, I think it's a good position, yeah? You got the good
This
position.
is what is the hip implanter's view. Yes, sir. This is the implanter's view.
Sir,
Good
this is
position. The middle marker is just below the sinus. I think this looks good. Any comment?
Sir, this
No,
looks
well,
beautiful. I think you will get a
the
90-10.
sinus line is just in the middle of the
Yeah.
dark.
What did Dr. Alain, what did you
I was saying that you have the dark band, and you have to put the dark band, the sinus line, in the middle of the dark band.
Yeah.
So this is exactly the position that you are expecting. Yeah,
Yeah.
It's excellent.
So
Excellent.
the advantage of pre-dilatation just goes without any struggling. Yeah, I think most of the time we try to struggle without pre-dilatation, and that's the time when the embolization goes up. That's my, I
So
think
if-
that way. Okay.
So if everyone agrees, we go ahead and then implant the valve.
Sir, it looks all good. I think from the panelist, I am also getting a
Okay.
go ahead.
Okay. Has it been pushed down? One. So, 1 minute. 1 minute. Okay. Ready? 180. Fluoro. Fluoro. Cine. Yeah. Ready? Cine.
His BP has come down.
Yeah. Cool.
It's
Commit. Commit. 1, 2, 3, 4. Down. Fluoro. Facing down. Okay.
the aortic pressure looks good, yeah?
Now the pressure has come up. ECG, any changes in the ECG? No.
Where?
We can do a injection and see.
Yeah.
Okay.
If you want to overdilate, are you using a balloon dilatation catheter, for example, a 26 or something, if
Yeah,
necessary?
we can, but let's see the angio
sure.
and take a gradient. We'll take a gradient.
Fluoro.
We'll take a angio first and then go with a pigtail and take the gradient and see if it is what is the. Okay.
Pigtail system. Tenses.
Sir, there is a lot of suspense about the paravalvular leak,
Okay.
waiting for an injection.
Yeah.
Okay. Inject.
Beautiful.
Doesn't look, coronaries are normal, doesn't look any
Well,
paravalvular
there is
leak. I think
nothing. This
you
is
want to take
again
it down
an
little,
optimal
just
result, yeah?
give one more injection. Just one more injection. Ready?
15 cc we will make.
Ah.
15 cc.
Ready? Okay. Okay, fine. One more injection.
Well, what do you want? What do you want, Pratap? Because the gadwar is still there, you know, so...
Guide wire is still there.
yeah, well, if you remove the gadwar, you won't have any leak.
Go with the pigtail.
Okay.
Or maybe a
So-
little on the side, you know, but...
So let me first take the gradient. Let me put a pigtail catheter into LV. We'll take the gradient and then we'll see what to be done. Okay. Take it out.
So your valve depth
See the
looks
LV.
excellent, sir. And some intravalvular leak should also get better.
yeah.
Let's see. See the pressure? Absolutely no gradient. Just see the pressure. So this,
Can you see? Look at the hemodynamic monitor.
can you see the hemodynamic monitor?
Yes, sir,
no
we can see
gradient.
that. Yes, sir.
Okay.
So we can take one more injection.
One more injection.
Okay. Ready?
Thoda.
Okay.
Okay, ready? Okay, no air.
Beautiful.
No air. That is it's going to the aorta. There's no air, you see?
Fantastic, yeah?
Sir, even on your
It's a
hemodynamics,
15 minutes
The
case.
beauty of well, no gradient, no air.
The diastolic is 70.
Yes, sir, absolutely.
There is a very trivial paravalvular leak.
Sir,
Yeah.
Very,
We can put.
just show once more.
Sir, every time when your rate picks up,
You
you
can
see a
imagine
very
some
good diastolic separation.
I don't find any paravalvular leak. You can
No,
imagine.
no.
There's nothing. And that's the type of result you get if you use a balloon expandable stent valves. So I think result most of the time is very good. And I feel the leak, paravalvular leak and air is much less in this balloon. What is your comment about
Well,
this?
actually, I think that this is a very acceptable result, you know. Yeah, maybe...
No, what about this paravalvular leak, air with balloon and self-expandable, between balloon and self-expandable valves?
Well, there is, you know, with this kind of balloon expandable valve, now the paravalvular leak is an old story. It does not exist anymore.
It doesn't exist.
No, with the self-expanding, our experience is that very often you have something. You have something. but
That's
it ca-
what Alain is saying, that with this balloon expandable stent, this balloon expandable valve, the paravalvular leak and all these things are things of the past. And sometimes you see some of these leaks with...
Not only that, you know, but there is no risk of pacemaker. There is no risk of permanent block.
Yeah, that is another. Permanent pacemaker implantation rate is very low with balloon expandable. I think it's more, with this my valve, it is much less.
And I would say another advantage of this valve, especially the my valve and the Sapien 3 too, is the easiness of placement and the precise positioning. You know, you don't have to think twice. You know, you just put the valve and deliver it, and that's it.
I think positioning is a little tricky with self-expandable.
Yeah.
With balloon expandable, its precise positioning is more often achieved.
Sure, of course, it makes a big difference.
So,
Especially for the beginners, you know, because...
and the ECG, there is no changes. And now I think sinus rhythm, narrow QRS. And so I think we'll take out the device now and we'll close with one...
you close with
no
stroke.
problem. We have already put one probe
glide and we'll upsize with another angiosyl.
Angiosyl will put one more angiosyl.
Looks very nice, sir.
They can go to other
Excellent. Is it possible to see the echo?
Yeah.
It looks a beautiful result, hemodynamically as
Okay,
well
sir,
as...
while you
close,
close, we can probably go to the second lab for the second case. Can we switch to the second lab, please?
Yes, actually we are closing and we are finished. And you can go to the second case from Apollo Chennai. And anyway, goodbye from our team.
Thank you,
This
sir.
is our last case. And see you next year. See you next year. Thank you very much for attending this course and this 2 days meeting. To all the delegates, faculty and everybody.
Thank you, sir.
Bye.
And thank you,
See you
Dr.
next
Manoj.
year.
Thank you.
Thank you, sir. Excellent
Thank
demonstration.
you, Ravindar.
Thank you.
Thank you very much, Dr. Rath and Dr. Manoj. That was an excellent case and an excellent meeting. It's one of the most enjoyable meetings in the last many years I've attended.